I want to bring Lisbeth and Enrique for the next session. And so, Enrique, over to you to chair the next session on multiple pregnancies.
Yeah. Thank you very much, Leona. Hello, everybody. My name is Enrique Gil from Lima, Peru. I am a fetal medicine specialist, and I'm going to be chairing the next session about twins. So our first speaker is going to be Professor Lisbeth Lewy, who is a fetal medicine specialist at US Leuven, Belgium, and an associate professor at the Faculty of Medicine of KU Leuven, Belgium. Her clinical work and research focus on complications of monochorionic twin pregnancies and their placentas. So, Lisbeth, if you are ready there.
Yes, thank you very much for the kind invitation to talk about monochorionic twins. I hope, wait, can you see my slides?
Yes.
Yeah, okay, thank you.
Yes.
So, yeah, the purpose of my talk was to illustrate how looking after monochorionic twins with prenatal ultrasound scan is actually looking for discordances. So monochorionic twins can be discordant for a structural anomaly. They can have severe amniotic fluid imbalances, which we then call TTTS. They can differ in hemoglobin levels, which we call twin anemia polycythemia sequence. And also they can have differences in growth. Now, my purpose of my talk was to illustrate how looking for discordances happens in monochorionic twin pregnancies. And I'm going to present to you 4 recent cases that we managed in our hospital. And so the first case was a young woman. She had a previous cesarean section because of placental abruption, and she was referred in the first trimester because of anencephaly in one of her twins. And this is actually the image. So what you can already see is when you look at the intertwin septum, this is a monochorionic twin because the twins are only separated by 2 thin amniotic layers, and you can clearly see the empty lambda sign. Sorry, this was not meant. So I can just go back. And when I scanned her, what we saw was obviously the reason why she was referred. So one of the twins had obviously a central nervous system abnormality, but it didn't look like the typical anencephaly that you see in the first trimester, because usually this develops into, the exencephaly develops into anencephaly. And here what you can see is actually a severe exterior presence of the brain that is still with skin around it. But if you look very, very carefully, you can see that this is the entire brain is actually attached to the amniotic sac. So this is an amniotic band syndrome with an encephalocele. Now, we know from the group of Professor Nicolaides that looking for anomalies in the first trimester is very important, and that we can pick up about 50% of all anomalies in monochorionic twin pairs. Now, whether it's anencephaly or exencephaly or an encephalocele with herniation of the entire brain, for the prognosis, obviously, this is a lethal condition where we expect demise of this baby in the early neonatal period. And then obviously the question is, what are you going to offer this patient? So obviously the options are expectant management with comfort care after birth, where we expect that the anomalous twin will pass away soon after birth. You can also offer a selective reduction, but then you know this has a 20% risk of losing the healthy twin as well because of miscarriage or co-twin demise. And then, at least in my country, you can also offer a termination of the entire pregnancy. Now, obviously, the least risk for the healthy co-twin in this scenario may well be to be expectant and to offer comfort care. of course, these are monochorionic twins, so you would need to follow them like all monochorionic twins and look for signs of twin-twin transfusion syndrome or other problems like discordant growth or twin anemia polycythemia sequence. Now, this lady was very committed to her pregnancy and she opted for an expectant management. And so we followed her very carefully with her referring physician, and this is a 20-week scan. And actually there was a concordant amniotic fluid. You can see the free-floating intertwin membrane between the babies, which means that both babies have normal fluid. This is again the anomaly where you can see that the entire brain and also the cerebellum was present in the encephalocele, and then also the amniotic band. And we followed her up to 34 weeks. And as I said, in monochorionic twins, you would look for twin-twin transfusion syndrome. And it's very important to look for the intertwin membrane, that you can see it free floating. If you have fluid on both sides, it means there's no stuck twins, so no twin-twin transfusion syndrome. Nowadays, we also monitor the middle cerebral artery peak systolic velocity to look for hemoglobin levels, which would indicate the presence of TAPS, and we also follow the growth. And this is actually the growth curve of the abdominal circumferences of the babies, and you can see that this pregnancy remained uncomplicated. But then by 34 weeks, she came contracting, and she had a short cervix, and she went into labor, and so the babies were delivered. And she delivered 2 girls, and this is actually the anatomical picture with the amniotic band and the large encephalocele, and this lady went home with a healthy baby. So what I want to say with this case is that obviously severe anomalies, and we know that in about 1 in 10 monochorionic twin pairs, there's an anomaly, and it's usually only affecting 1 baby. And for the management, you always have to think about the healthy twin. And for lethal anomalies where you expect that the baby may die soon after delivery, it may be reasonable to adopt an expectant management. My second case is a case that came for routine follow-up. We offer to our referring gynecologists to have a detailed scan in the first trimester at 16, 20, and 28 weeks. So she came for a routine follow-up of her monochorionic twin pregnancy. And this you can also see, this is a monochorionic twin pair. And we followed her up, and actually everything was fine until around 30 weeks, where we saw that the growth of the baby, and this is the growth curve, that the growth of the babies became progressively discordant. And these, I always recommend to map the 2 abdominal circumferences next to one another, because you can easily then spot any discordances in size, but also in echogenicity of the liver. Because actually this case, when we measured the middle cerebral artery peak systolic velocities, and we saw that there was a discordance, there was a higher peak systolic velocities in the smaller baby than in the larger twin, which indicates that this baby might be anemic and this baby might be polycythemic. And then if you look back at the liver of the presumed polycythemic twin, what you can see typically in twin anemia polycythemia sequence is that you have, besides the discordances in middle cerebral artery peak systolic velocities, you have a dark liver with the bright venules lighting up. And this image we call the starry sky aspect. And then when you look at the monochorionic placenta, which is in fact one single placenta, in twin anemia polycythemia sequence, what you will see is that the part of the polycythemic twin is very dark and thin, and the part of the anemic twin is very white and thickened. And this we call placental dichotomy. And both the starry sky liver and the placental dichotomy indicate the presence of twin anemia polycythemia sequence. Now, in this case, you can see that actually the one with the higher middle cerebral artery peak systolic velocity it didn't cross the 1.5 multiple of the median. So we did not expect this baby to be anemic. However, we gave steroids, and then she started decelerating on her CTG, and we had to deliver the babies. And so at birth, actually the one that had increased peak systolic velocities was anemic. It had a hemoglobin of 8 grams per deciliter. And the polycythemic twin was also indeed polycythemic. And this baby needed a transfusion after birth, and this baby needed a partial exchange transfusion. And this is the placenta after birth, and I still have a passion for the monochorionic placenta. And actually what you see on these TAPS placentas is what you also see on ultrasound scan. So a white thickened part of the anemic baby, and then a dark part of the polycythemic twin. And just looking superficially, you would think there are no communications between these babies. But in fact, if you do careful color injection, you see these tiny communications between the twins, which is typical for TAPS, because TAPS pregnancies, they don't have a severe difference in amniotic fluid, but they do have a severe difference in hemoglobin levels. And that's because these tiny vessels, they allow for a chronic slow net transfer of red blood cells from the donor to the recipient baby. And so if you don't inject the monochorionic placenta, you can also turn the placenta around. And then if you look at the maternal side, you see this typical placental dichotomy. And this allows you to differentiate with an acute intrapartum transfusion, because obviously for these differences to arise, it must be a chronic transfusion imbalance. And this is typical for TAPS. Now, twin anemia polycythemia sequence is similar to twin-twin transfusion syndrome, an imbalance in blood exchange between the babies, but in TAPS, you only have the isolated difference in hemoglobin, whereas TTTS is characterized by a severe difference in amniotic fluid volume. And we know that TAPS is more rare than TTTS. It only occurs in about 3% of all monochorionic twin pairs. And also in contrast to twin-twin transfusion syndrome, TAPS usually occurs in the viable period, and that makes that delivery becomes an option when it occurs, especially after 30 weeks of pregnancy. The third case was a case that was referred in the early second trimester at 18 weeks, and she was referred because of a type 2 selective fetal growth restriction. So there was a 34% difference in estimated fetal weight. And it was called the type 2 because you have the absent and continuous absent end-diastolic flow in the umbilical artery of the smaller twin. However, the ductus venosus was still normal. But when I scanned her, what is striking here is that you can see that it's not only a difference in size between the babies, but it's also a very early TAPS sequence. So you see here the starry sky aspect of the polycythemic recipient and the typical placental dichotomy. And this was confirmed by the measurements of the middle cerebral artery peak systolic velocities. Now, at 18 weeks for TAPS is a transfusion imbalance. So we theoretically coagulating the anastomosis like you do for twin-twin transfusion syndrome would be a curative treatment. Also, you could offer an intrauterine transfusion of the anemic baby, or in countries where this is allowed, parents can opt for a selective reduction. Now, in this case, the donor baby was completely stuck to the posterior wall, and in very early TAPS, because TAPS can occur late in pregnancy, but many cases also present very early, from 16 weeks onwards. Obviously, the options for invasive fetal therapy are more limited, and in these very early TAPS cases, we prefer an initial expectant management just to see how the anemia, the discordance in hemoglobin levels will evolve. And in a significant proportion of early TAPS cases, we know that they either remain stable or most commonly they disappear spontaneously. And so in this case, when we saw her back, the discordance in hemoglobin levels remained stable. But then as pregnancy progresses, we saw a progressive normalization and spontaneous disappearance of the twin anemia polycythemia sequence, and also the story sky aspect of the liver disappeared, the placental dichotomy disappeared, and also in the smaller twin, there was a reappearance of the absent of the end-diastolic flow came back. So it theoretically became a type 1 selective fetal growth restriction. Now, the pregnancy progressed well, but obviously the donor baby, the ex-donor baby of the TAPS remained very small. And at 32 weeks, she also had spontaneous decelerations on her CTG, and we delivered the babies. And this is the placenta. So the smaller baby was really, really small, only 740 grams. So whereas the bigger co-twin was 1,700 grams. And these placentas of early TAPS cases that disappear spontaneously, typically if you inject these placentas after birth, you don't see any anastomosis. And that's also the hypothesis that when you have a very early TAPS, you know that there are tiny communications, and you also know that the placenta will grow a lot in the remaining of pregnancy. And so the hypothesis is that a lot of the very early TAPS cases can resolve spontaneously because of spontaneous closure of these tiny communications. And then my last case, this case was referred because of a twin-twin transfusion syndrome at 19 weeks. It was a type 2 because both babies still had normal Dopplers. And you see the polyhydramnia, so at 19 weeks, this was 9 centimeters, so it was more than 8 centimeters, and the polyuric recipient baby, whereas the donor baby had less than 2 centimeters, deepest vertical pocket with an empty bladder. But when we scanned her, what we saw was that besides the difference in amniotic fluid volume, at the same time, we saw differences in middle cerebral artery peak systolic velocities, and we also saw the typical starry sky aspect of the polycythemic recipient. When we looked at the placenta of this TTTS case, we also saw the typical placental dichotomy that you see in TAPS. And so because it is a TTTS, and TTTS, we know from randomized controlled trial that the best treatment is laser surgery. Whenever you have the combination of severe amniotic fluid discordance with also severe difference in hemoglobin values between the babies, well, the best treatment should be fetoscopic laser surgery. And we know that in these TTTS combined with TAP cases that they usually present a little bit later than the TTTS without combined TAPs, and also that they have fewer anastomosis. Usually there's only one AV and one VA communication present. And so this case delivered at 35 weeks. And as you can see, as Professor Nicolaides has been doing from the beginning, we draw a line across the placenta when we perform laser surgery for twin-twin transfusion syndrome, because this is also to avoid that we miss tiny anastomosis and that we have twin anemia polycythemia sequence after laser treatment. So this was my case presentation. So I wanted to highlight that when you scan monochorionic twins, you look for discordances, and these can be discordances in anomalies, discordances in amniotic fluid, in hemoglobin values, and in growth. And obviously, what is most important is when there is a severe anomaly in one of the twins, because this will obviously determine your management. TTTS also overrules a TAPS or a selective fetal growth restriction diagnosis, in the sense that we know that whenever you have a TTTS, laser treatment is the best option. And so, yeah, that was what I wanted to share with you today. Thank you.